Well, thank you for coming. Did you have a particular reason, Emmy, why you wanted this topic covered?
Just because I've heard a lot of questions with volunteers kind of around, especially with the occupational and physical therapy clients, kind of what does this do for our clients? How is this helpful? They're part of classes, but I know a lot of the reasons behind certain activities or certain movements is very linked to those OTPT goals. And sometimes the volunteers don't necessarily, they don't have that high level of information about a writer. So a lot of times it's harder for them to see exactly why this is or what this is doing. They can tell it's being helpful, but they can't really define and categorize why it's helpful.
So I guess what I would say to start with is it always starts with a good physical, occupational, or speech therapy evaluation. Because I'm a physical therapist, my lecture this morning is going to kind of be geared towards what I would look at as a physical therapist, but it would be very similar to what a speech therapist might do or an occupational therapist might do. So to just kind of start with that basis, because this utilizing the horse, utilizing equine movement is really a treatment tool in my toolbox as a physical therapist. So it always has to start with a good evaluation. So when I do a physical therapy evaluation, I start by looking at just some history. So I need to know what the age of the person is, what their height is, what their weight, what their diagnoses might be or are. And for a lot of these individuals, they have multiple diagnoses, not just one. Recently, in the last probably 5 to 6 years, because of the groundbreaking work that they've made in genetic testing, there are so many new diagnoses out there now that are, just simply a genetic, there's a deletion or an addition in a genetic code. So I often have to just look up what that is because there's so many new ones. You can't keep up with all of them. So I will often go to one of my medical websites to try to find more information about that specific diagnosis. It's really important to know if they do have multiple diagnoses or comorbidities, as they call it, because that can also affect how my treatment plan will be developed. So if they have, for example, I have a young rider or young patient who has a diagnosis of cerebral palsy, but she also has a diagnosis of cystic fibrosis. So I have to look at both of those diagnoses and see how it could affect what my treatment plan is going to be for her. I'm also going to look at what her medication, or look at what the medications are that the individuals are on. Because certain medications can have side effects or other issues that will also affect my treatment plan. I'm also going to look to see if they have a seizure disorder, because that'll be something really important to know if I'm going to utilize equine movement in my treatment approach, about the precautions that I might have to take if they do have a known seizure disorder. I'm also going to look at their past medical history. I'm going to look to see about surgeries that they have had or may have coming up. I'm going to look to see if if they have shunts or implants, total hip replacements. Any of that kind of information is also going to be important for me to develop my treatment plan. Everything I've talked about to this point, I get from the parent or the guardian, but I will also need to get that information from the physician. A lot of times the information that, is more accurate on the physician's physician's release form than what I get from the parents, especially when it comes to height and weight. That tends to be a little bit more accurate from them. But I also will spend quite a bit of time talking with the parents or the guardian and the patient themselves to ask them, what are your strengths and what are your goals for therapy? What are your, and it can be related to school, it can be related to work, it can be related to function. It just kind of depends on the situation, depends on the age of the patient and what what their goals are. So that usually happens initially in just my general observations. I'll be sitting there talking with the family or talking with the patient, and I'll be observing them just to kind of get an idea of how they function in their environment, how they act, how, if there's any, anything that comes up as far as social, emotional, or behavioral issues, even though that is something that is not in my scope of practice, it's still important information that I need to have. For example, I had a young man several years ago who was on the autism spectrum disorder, and he was pretty involved behaviorally, and he had a tendency to, when he was just during the evaluation, was constantly attacking mom and hitting mom, and he had a history of that at home. So that was something that I needed to know in order to be able to prepare a treatment plan that would help us deal with that issue. And one of the things that I found, and it was interesting, it kind of happened by accident, so that I know as a therapist that kids and adults with autism like deep pressure inputs. That's a sensory technique that can help have a calming effect for him. So we would do that while he was astride the horse. We would do some what we call joint compression to really try to get him to remain calm, and it really helped. But the kicker was that in the winter months, I was wearing gloves that had the little nubbies on them. And when I would squeeze his hands with those little nubbies on them, he just completely relaxed on the horse. And we rarely would see that hitting behavior from him because of that. So that was, and again, it was just something that I learned by accident. But getting back to my evaluation. So the next area that I look at is the functional skills and their ADLs. So a lot of this will come from the parent or the patient report, but I can also observe this in the clinic. So I will look at their sitting balance. I will look at their ability to stand. I will look at their ability to, their mobility. So are they able to ambulate? And if they can, do they need an assistive device to do that? Do they have braces that they need to wear? Do they need a wheelchair because they're not able to ambulate? We'll also look at their transfers. So are they able to transfer independently in and out of a wheelchair? Or are they completely dependent in doing that? What does their bed mobility look like at home? Are they able to reposition themselves in bed, or are they not? Sitting, if they are they able to sit independently to make it easier for mom and dad to get them dressed? Or do they have to lay down in order to that? So I kind of look at all of those skills. I'll also look at their musculoskeletal system. So I'm going to look at their range of motion. Do they have tight hamstrings? Do they have tight adductor muscles, which are the inner thigh muscles? Do they have decreased range of motion in their shoulders or in their arms? And while I'm assessing that, I'm also looking to see if there's any tone in those muscles. So individuals can have increased muscle tone, which is spasticity, or they can have low muscle tone, which means they're really kind of flaccid. I'm also looking at their posture to see how they sit or how they stand. Are they kyphotic? Do they have a scoliosis? Those kinds of things. I'll also look at their gross motor skills, and that's a little different from their ADLs because I'm looking to see where they are in the developmental sequence. And by developmental sequence, I mean every baby that's born goes through a specific set of skills, from not being really able to do anything to be able to hold their head up, to being able to roll, to sit, to get into kneeling, or to quadruped, which is on hands and knees, to kneeling, to standing, to walking. So every child does it at different rates, but they go through the same developmental progression. And I need to know where they are on that spectrum. You know, are they able to hold their head up against gravity? Is it something as basic as that? Are they able to sit independently? Are they not able to sit independently? Do they need assistance? So I just kind of want to know where they are on that spectrum. And then I kind of look at it from a neuromotor standpoint as well, looking to see if they have any abnormal reflexes that were never integrated, or if they have that increased tone, kind of like I mentioned a moment ago when I was talking about the musculoskeletal system. I will look at their fine motor skills, but just in general, I leave the whole, the really in-depth evaluation of fine motor skills to the OTs. That's not in my scope of practice, but I do want to know, do they have do they have a grasp? Do they have a release? Just some of those fine motor things that we might need is, can they hold onto a piece of paper, just some general fine motor skills. It's also important for me to look at their skin integrity. I need to know that they don't have skin breakdown, especially on their ischial tuberosities, which is their sits bones, or if they've had issues with skin integrity in the past, because that will also influence whether I feel that equine movement would be beneficial for them, or if it's going to be a risk factor for them if they have had problems with skin integrity in the past. I like to look at their respirations, both resting and with activity, and that kind of leads to also what their cardio state is, and what their endurance level is. That'll help with my treatment plan as well. Can they tolerate a full 30-minute session on a horse? Do I notice that when they are exerting and when they're in activity that their respiration rate goes up significantly? So that's something that I have to factor in as well. I also look at their proprioception. The proprioception, there's two parts of this, is knowing where their body is in space, but also knowing, like, if I touch a certain part of their body, that they know that that is where I'm touching them. So those are also important components of knowing whether equine movement is going to be beneficial for them or not. So I can recap real quickly for you, but I look at what their diagnoses are, what medications that they're on, whether they have a seizure disorder, what their past medical history might be, whether they've had surgeries, shunts, that kind of thing. I'm looking at their, I spend a lot of time speaking with either the patient or the parent or the guardian about what their strengths are, what their goals are for therapy. I look at their functional skills, their ADLs. I'm looking at musculoskeletal system, so what the range of motion might be, strength, their posture. I look at their gross motor skills. Are they able to walk? Are they not able to walk? Are they able to sit independently? Are they not able to sit independently? I look at the neuromotor system to see if there's any reflexes or muscle tone that might be going on. I do look a little bit at fine motor skills as a physical therapist. That's not in my scope of practice. I leave that to the occupational therapists, but I do want to know, do they have a general grasp and release? Can they hold a piece of paper? Just some, things that I might need to do during therapy. I look at their skin integrity, because if they have issues with skin breakdown, especially on their sits bones, that can affect their ability to be able to sit on a horse. I look at their respirations, especially during activity, to know what their endurance might look like. And then when you came in, I was talking about proprioception. I'm looking to see if they're able to know where a body part is in space, and or if they know, like, if I touch their knee, that I'm touching their knee. If they, I also look at communication. Again, most of it I would leave to a speech and language pathologist, but I need to also know what means of communication that the family or the patient has. Do they know sign language? Are they verbal, or do they just have vocalizations and you have to learn just through facial expressions what they're trying to communicate to you? Do they have a communication device? I have had patients that actually have they call them touch talk, and we program into the thing that into their device that one button is for walk on and another button is for whoa, so that we can work on some basic communication. I spoke a little bit earlier, but any behaviors that they may have, especially with some diagnoses that their behaviors might be more prevalent than others, i.e. autism. I also want to know what other adaptive equipment that they might have. Do they, if I mentioned earlier, I look to see if they use a wheelchair. Do they have adaptive devices that they might need for walking, such as, you know, splints or AFOs or that kind of thing. But what other adaptive equipment do they have or do they need? And then I also look for safety concerns and or contraindications. Some of that information I'm going to get from the physician's release form. But just again, for my general evaluation, I'm going to look to see what some of the contraindications might be. So for example, if an individual has osteoporosis, and that would be a red flag for me, that utilizing equine movement would they'd be at higher risk for fracture using equine movement. Not necessarily maybe being on the horse itself, but if there is if they ever fell off of the horse, they could definitely sustain a fracture. So it's not it doesn't exclude the person, but it's definitely something that I have to be cautious about. Talking about the skin integrity and pressure areas, that's something that I have to be aware of. So if I have somebody that I know has a significant issue with skin integrity, I will use I have a really nice sheepskin pad that I use for them to sit on that provides some pressure relief and less chances of causing friction that could cause skin breakdown. Where my range of motion comes in is if somebody has very, very tight hip abductors, which are the inner thigh muscles, they may have a really hard time getting their legs apart to be able to sit astride a horse. So I might, you know, it would depend, do I have a horse that's narrow enough for me able to put this person on? And if I don't, then equine movement may not be the treatment tool that I utilize for that individual. Other safety concerns that I look at is the size of the person as well. If I have a young person, a patient who is not able to sit independently on a horse, and they're rather large and it's too difficult for myself and a sidewalker to hold that person up, then I may not utilize equine movement as my treatment tool, for example. So anyways, I look at all of those factors, and that's when I develop my goals for our therapy. So again, I'm looking just as a physical therapist, and what are my goals for this person, and then what's the best way to achieve those goals. So that's when I would determine if equine movement as a therapy tool to engage the sensory, neuromotor, and cognitive systems will promote those functional outcomes that I'm trying to achieve. Okay, so I could decide that, you know, maybe initially that's not the case, that I would rather work on having them do some work on a therapy ball. Or I might say, well, we're going to start with a therapy ball for the first 5 or 10 minutes of therapy, and then we're going to go get on the horse. Or, you know, we're not quite ready yet. We need to get some work on your adductors. We need to do some stretching. So I might start with, you know, therapy that way, and maybe working with the physician to say, you know what, I really think that we could achieve some other goals for this patient if he had more range of motion. So could we look into doing like phenol blocks or Botox injections to that area to improve the range of motion so that we could then work on other therapy goals. Okay, so it still is, you know, working in that team approach. I often get asked, you know, so why do you pick the horse over other treatment tools in your toolbox? Well, for me, there's a lot of different reasons, but the one that I talk about the most and you hear about the most is that the equine pelvis moves identical to a human pelvis when they're walking. Okay, so it's the same degrees of rotation. It's anterior, posterior, it's lateral, it's side to side, and then that rotation piece. So the only difference is that because we only have 2 legs, our pelvis is vertical. And because the horse is on 4 legs, their pelvis is horizontal. Okay. But so when a horse is walking, when their pelvis is doing their anterior, posterior, or moving forward and back, that's the same as what's happening in our pelvis. When a horse is getting rotation, when their pelvis is going side to side, that's actually providing, or when their pelvis is rotating, that provides a side to side motion in the rider or the patient. And then when they are doing side to side, that's providing the rotation for the rider. So, but in general, the movement is identical. If you can Google, there's some really cool videos out there that will highlight this. It's called the dot demonstration. If you just Google dot demonstration, you'll see where they show a video of somebody walking and then a horse walking, and they've got dots on the person and dots on the horse, and you can see how the pelvis and in both people, the horse and the person, are moving identically, which is really kind of cool. The other thing is that when you're mounted on a horse, the horse typically takes about 100 steps per minute. Okay, so in 5 minutes of walking, that represents 500 neuromotor endpoints to the patient. In just 5 minutes, you're getting 500 neuromotor inputs. So a typical session lasts 25 to 30 minutes. So you're getting 2,500 to 3,000 neuromotor inputs, normal inputs for that patient. That's a powerful way of getting a consistent and rhythmical and typical movement that is very difficult. You can't replicate it in a traditional therapy setting. So that's really kind of neat. The other big thing for me, especially with my younger patients, is that most of them are born with a disability, and they've been receiving some form of therapy services since they were infants. And they get to a certain age, usually happens right around kindergarten or so, that they start to be like, nope, I am done with traditional therapy. I hate it. I'm bored with it. I'm frustrated. I don't want to do it anymore. You put them on the back of a horse and it changes everything, because they don't realize that they're getting therapy, you know? And it's fun for them. It's a fun activity, but at the same time, they have no idea that you're actually working on their posture. You're working on their trunk control. You're working on reach. You're working on their ability to ambulate. You're working on their ability to do transfers. They don't realize that they're doing all that while you're doing your therapy sessions, so that's pretty powerful. Not only that, but there's like I said earlier, you're engaging so many different systems. You're engaging the sensory system, you're engaging the neuromotor system, you're engaging the cognitive system. And again, that is nearly impossible to replicate in a traditional therapy setting. And yet you need to engage all those systems together in order to get your functional outcomes, whatever your goal may be. So it can really be a pretty powerful form of therapy. There is lots of research out there now to support this claim that they are making, that this can be a very efficient and effective way of providing therapy. It's now, we're just battling Medicaid insurance companies to get them to get on board with it as well. So that's all I had to say. Does anybody have any questions or something you want me to go into more detail about? It always can look similar. It really can. So for example, you might see one of the occupational therapists have their patient working on steering their horse and turning and reining and all that kind of stuff. But they have an actual occupational goal. And I'm sorry, is it Jenna? saying it incorrectly, but anyway, as an occupational therapist, you can see where you could come up with an actual functional goal that would relate to being able to do a button or do a zipper or tie your shoes by steering using the reins. Whereas a riding instructor is going to say they're learning to steer because that's how you learn to ride a horse.
I see.
So their goals would be totally different, although they may be doing the same activity.
I see.
So it's important to, know those delineations and those differentiations between the two.
Absolutely.
And it doesn't hurt to ask. It doesn't hurt to ask.
Yeah, I ask, I'm not shy about,
Well, that's good.
I don't care how silly I look or sound or anything else,
That's,
Yeah.
You know what? It's always good to ask questions. I always like it when my volunteers ask questions.
Yeah, I don't know what I don't know. So, and I appreciate all of you. So I'm learning a lot.
There's a lot to learn.
I
There's
know.
a lot to learn.
I know. There is. It's going to be, lifetime.
Yeah. I always continue half of the lecture series topics I came up with were just things I wanted to know about. It's like, I want to learn. Let's see if anyone else wants to join me.
There you go. I love that.
Yeah, I do. I love it. It's so great.
Yeah, I guess the takeaway from this is that if we get a referral for a person who might want to participate in the therapy services program, what we're going to do is we're just going to start with our basic evaluation, and that's not going to be on the horse. It's going to be in in a traditional clinic setting, and I'm going to do my typical physical therapy evaluation, okay, and to look at what the issues are, what the goals are, and once I've done my evaluation and come up with a treatment plan, okay, so these are the tools that I have in my toolbox, one of which is using equine movement. Is that going to be something that I can use to achieve the goals that I've developed? Versus, somebody who's going to be in our therapeutic riding program, they come in, they have this disability, but in essence, what they're going to be learning is how to ride a horse, but the instructor may have to adapt how they're teaching them those skills based upon their disability. So the goals are different.
Do you ever work in unison together? Like
I often will provide consultation to the instructors. They might ask me, I'm having this issue. Say, for example, I had an instructor come to me yesterday. She has a person that is having a hard time sitting on her horse. She's got something. She does something weird with her right leg. She's kind of holding it out to the side, but her left leg looks good, but the right leg doesn't look so good. So I said, well, what you need to do is make sure that her pelvis and her sits bones are level on the horse. That's the building block. You got to start with the pelvis, and then everything can go, up and down from there. And so I wasn't able to actually be at the class with her, but I asked her afterwards how it went. She goes, oh my gosh, it made all the difference. Once I made sure that her pelvis was level, and then that she was sitting on both of her sits bones evenly, the right leg corrected itself. I'm like, okay, there you go. So yes, I will often provide consultation for that kind of thing.
Okay. Awesome.
This helps to make sure that, that they're getting the best experience that they can.
Yeah. And just walk away happy and smiling like I do on Tuesday mornings working with, even though I'm like, I got an F on that. I think I got a B on that.
Yeah.
It's great.
Well, if you guys don't have any other questions, thoughts?
I will. The more I'm involved, I'll have for you.
Yeah.